Health Watch is presented by UMass Memorial Health Care. Here, caring for you.
There are reports stating that there are overdiagnoses or false positives with mammograms. What are your thoughts?
Overdiagnosis is actually a very small percentage of patients, and actually we see 0 to as little as 1% overdiagnosis of invasive breast cancer. An invasive breast cancer is cancer that occurs in the duct, has invaded through the duct, and then has potential to metastasize to the lymph nodes and then elsewhere. That's the kind of breast cancer we're most concerned about, and we see minimal to no overdiagnosis in invasive breast cancer. However, with in-situ breast cancer, which is breast cancer within the duct that has not invaded through the duct wall, which doesn't have a potential to metastasize, that's where we see the overdiagnosis. And even then, studies have blown this out of proportion by using data that's incorrect. And some of the more recent studies have had a bad methodology that has shown an incorrect percentage of overdiagnosis. It's really most likely somewhere between 2 and 10%, most likely more around 2%. And it's only in the in-situ cancers.
Is overdiagnosis the same as being overcautious?
Overdiagnosis is not being overcautious. It's that we don't have all the information we need because there needs to be further research into which type of in-situ breast cancer is clinically significant and which isn't.
How often and why does overdiagnosis occur?
The reason we see it is because if left alone, almost all in-situ cancer will progress to invasive cancer, the kind of cancer we're concerned about. The problem is, as of right now, we have no way to predict whose in-situ cancer is going to progress to invasive cancer in months to a year, and whose might not progress to invasive cancer for almost over a decade. And until we have more molecular medicine, which is out of the realm of imaging, and there's more molecular tests on the cellular molecular level we can do to see which ductal carcinoma in situs will progress to invasive cancer quickly versus won't progress quickly. Overdiagnosis is going to occur because we want to prevent as many breast cancer deaths as possible, and we'd hate to leave an in situ cancer in just because some of them won't progress to invasive cancer quickly, but others will. And so if you are one of those people who has one of those in situ cancers that will progress in months to a year to an invasive cancer, you want that out. And so the people who get overdiagnosed are the ones who wouldn't have progressed, but we have no way of knowing how long it's going to take for it to progress. So until we have further research on that, the best option is to take out all in situ cancers to save the most lives.
What is the procedure for treating in situ cancer?
None of this is a blanket rule, so I don't want anyone to hear what I say and think that everyone with in situ cancer gets a small lumpectomy, because some patients get very large areas of in situ cancers, and it all depends on your personal breast size and your diagnosis. Most in situ cancers can be dealt with a small same-day surgery lumpectomy where they just take out the in situ cancer and some of the tissue around it, and then most of those patients go on to have a couple weeks of radiation therapy. As opposed to patients who have invasive cancer that's detected very late, those patients will have a more extensive lumpectomy or even a mastectomy, and most of those patients, if it has spread to the lymph nodes, will require chemotherapy. So any in situ cancer left that progresses to invasive cancer could result in more aggressive treatment.
Are there more false positives with 3D mammography?
3D mammography cuts down the rate of false positives and cuts down the callback rate from mammography in general. And it's also shown to increase the detection of invasive cancers. Those are the ones that don't have overdiagnosis. So it decreases the false positive rate from mammography, and increases the invasive cancer detection. Now, the one thing is, most ductal carcinoma in situ, 90%, presents as calcifications, and that is not as affected by the 3D mammography as the masses or the big masses. So there's still, with calcifications, there's no great tool yet to decrease the overdiagnosis rate.
How difficult is it to differentiate between calcification and in situ cancer?
So we can, to a point, we can see which ones are more suspicious and which ones are less suspicious, and we can biopsy them. And then we get ductal carcinoma in situ. However, again, that's where people talk about the overdiagnosis, because we will not know if your ductal carcinoma in situ would become invasive cancer next month or next year versus 10, 20 years from now. And that's where the problem lies mainly.
Should patients only use 3D mammography?
3D mammography has been shown to increase the detection rate of invasive breast cancers by 50 to 58% in patients with heterogeneously dense and dense breasts, and in those patients 40 to 50, which is the controversial group. A new study out of Mass General actually showed that even in patients without dense breasts, who have fatty breasts or only a little breast tissue, they can actually increase detection rate of invasive cancer with 3D mammography by 30%. So it seems like it's benefiting everybody. Each state and each insurance company is different as to if they cover 3D mammography. My recommendation is if 3D mammography is covered, and you can get it, that it's always great to get 3D mammography. Now, you don't just get 3D mammography, you get 2D, 3D. You need both because those calcifications we talked about, which finds that earliest form of cancer, is easier and better detected on a 2D mammogram. But invasive cancers are better detected on a 3D mammogram. And with a 3D mammogram, you're less likely to be called back for just simply overlapping tissue, which would be one of those false positive mammograms. And it decreases the rate of patients called back for false positive mammograms. So my recommendation would be to get 3D mammography if possible.
What advice would you give to women when it comes to mammograms?
If you are younger, especially if you're between the ages of 40 and 50 and you're trying to decide if you should get a mammogram or not, the American College of Radiology and the Society of Breast Imaging both recommend you get annual mammography starting at age 40. But if you are between that 40 and 50, it's worth getting the 3D mammogram because we've seen less false positive mammograms when 3D mammography is used, and we've seen increased rate of diagnosis of invasive cancers that might have been missed had only 2D mammography been used. Overall, everybody can get 3D mammography, and it is recommended given some of the most recent data. Now, a large multi-center trial is about to start called TMIST, which is they're recruiting centers. It's an Akron trial, which is a big research group, funding group. And it's they are the group that previously did the DMIST trial, which showed that digital mammography was better than analog. So once we have that, we'll have more concrete data. But for now, all the preliminary data shows that 3D mammography decreases callback rates, in other words, false positives, and it also increases the detection of invasive cancers in all breast densities.